But once the patient is a red flag, you need to arrest the patient. You stop the patient. You either conduct an OPD arrest or an emergency arrest. You send the patient to the ER. Remember, malignant hypertension is a subset of hypertensive. When the person starts having headache, dizziness, blood fishing, then you are going towards the complications of hypertension. Hi everyone, welcome to Dr. Mira Teaches. We are going to look at the clinical features and investigation of hypertension. Now, when you look at this table from the American Heart Association, you will be tempted to zone out because the values look all over the place and the table looks a bit stuffy. But don't worry, I'm here for you, all right? I am here to make things clearer for you. All you have to do is to know your green flags and your red flags. Remember the nursery school rhyme, the rhyme we used to sing. If you see a traffic light, there is something you should know. Red means stop. Yellow means get ready. Green means go, 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 and go. All right. So if the patient is a green flag, sorry, if the patient is a green flag, the person is free to go. But once the patient is a red flag, you need to arrest the patient. You stop the patient. You either conduct an OPD arrest or an emergency arrest. You send the patient to the ER. Okay, so you need to know your green flags and your red flags. Now, what are the green flags and what are the red flags that you are supposed to know? Let's go back to the table. Now you'll see that this table looks better. Okay, this table looks better. You see that this is green. So here's where your green flag is. Okay, so we have one green flag and we have two red flags. Okay, now the green flag is a normal blood pressure, which is a BP of less than 120 for systolic and then for diastolic less than 80 millimeters of mercury. So this is your green flag. You see a patient with this green flag, let the patient go scot free. All right, now let's go to the red flags. You see, we don't just have one red flag. We actually have two red flags. We have a darker shade of red and a lighter shade of red. So the lighter red flag is a blood pressure of 140 or higher for systolic or 90 or higher for the diastolic. Okay, so that's the first red flag. Now, the second red flag is the darker shade of red flag. That is a more serious red flag as compared to this one, which is a BP of 180 or higher, and then for systolic and the diastolic of 120 or higher. Okay, so this is how you can simplify the table for yourself. But we are not done. Remember, the BP is less than 120 or 8 on 80 millimeters of mercury for a normal blood pressure. Okay, this patient is a green flag and is free to go, but you flag the patient. All right, give the patient a red flag if the BP is 140/90. Here you conduct an OPD arrest. Okay, send the patient to the OPD and do your thing. Okay, but a BP of 180, all right, on 110. So in our part of the world, we use 110 as our benchmark for the diastolic. Okay, 110 to 120 millimeters of mercury. You send the patient straight to the emergency because the patient is having a hypertensive crisis. Okay, so now there is something that you should also know is the fact is that here in our part of the world, and I think according to the European guidelines as well, blood pressure, okay, a person has a high blood pressure if the BP is greater than 140/90. All right, greater than 140/90, which is our first red flag. Okay, so here in Ghana, we still go with 140/90, and in some parts of the world, we still go with 140/90 as high blood pressure. However, according to the American Heart Association in 2017, a consensus was made, and now going 10 steps lower, all right, that is a BP of 130 to 139 systolic, and then 80 to 89 diastolic is considered hypertension, but that is stage 1 hypertension. All right, so this is stage 1 hypertension. And then the first red flag is actually stage 2. That's according to the American Heart Association. So this was what the Americans will use. Once you're at 130, 139, you have stage 1 hypertension. Okay, but the red flag is when you have a BP of 140/90, which is what we use here. All right, that's what we are using here. Of course, we are trying to, some are trying to adapt this. Okay, but then a BP of 140/90 is considered hypertension. Straight up, red flag, arrest the patient. Okay, okay. And In between these, the green flag and the red flag is considered elevated depending on the part of the world you are in. So this is considered elevated BPs. But if you are in the US, okay, BP of 130 to 139 is considered stage one. So this is where elevation comes in. Just when you have a BP of 120, 129, and then a diastolic of 180, less than 180, this is considered elevated. But in other parts of the world, both this and this are considered elevated. All right. It's not considered stage one. This is considered elevated. All right. And the actual high blood pressure starts from here, where your BP is greater than 140 or 90. So it all depends on where you are. All you have to know to make it very simple for you is to remember that you have a red flag and you have a green flag. Your green flag is your normal blood pressure, which is a BP of less than 120, 80 millimeters of mercury. The person is free to go and enjoy life, all right? But if the patient has a red flag, which is a BP of greater than 140/90, you straight to the OPD. You need to arrest the patient and want to start therapy for the patient. Okay. Then we also have the higher red flag, a senior red flag, a more serious red flag, which is a BP greater than 180, 110, if you are in our part of the world, 110 or 120 millimeters of mercury. All right. So this is when the patient is in hypertensive crisis. When it comes to the staging, you need to go 10 steps down below the first red flag. That is a BP of 130 to 139, and that will give you your stage one hypertension. All right. Okay. And then when the diastolic is also less than is between 80 to 89, you have a stage one hypertension. So 10 steps down, and then you have stage one hypertension. All right. Then your red flag stage two hypertension will be a BP of 140 or 90. Okay, higher than 140, 90. Okay, then you go higher. A more serious red flag is when the patient is in hypertensive crisis, having a BP greater than 180 or for systolic, or a BP greater than 110, 120 diastolic. Okay. Anything in between your red and green flags, we consider that elevated. Okay. Unless you are in the US where your stage one hypertension falls here, which is 130 to 139 for systolic and then 80 to 89 for diastolic. So this is how you should be able to remember the values for blood pressure. Okay. Now, for the red flags, let's go deeper and deeper into the red flags. For hypertensive crisis, we have established that a BP greater than 180 for systolic and then 110 to 120 millimeters of mercury diastolic is considered hypertensive crisis. But I'm sure you've heard of the term hypertensive urgency and hypertensive emergency. And it can be very confusing for a lot of people. Is it urgency? Is it emergency? What are we dealing with? Okay, it's very simple. Don't stress at all. You say that the patient has hypertensive urgency. Okay, when the patient has this value for the BP, okay, but then there are no signs of end organ damage, so no symptoms. Patient comes to you, is walking, is smiling, okay, giving you some nice, killer walk, killer moves, nothing. You check the BP and you are getting very high values, all right, that patient is in hypertensive crisis and it's an urgent situation because the patient may progress to having end organ damage. But we are in a lucky window where the patient doesn't have end organ damage as yet. So that is why it's called hypertensive urgency. There are no signs of end organ damage. Okay, so that's the meaning. So just a high BP, then you are having hypertensive urgency. Remember, this is what the value is. Okay. Now, what's the second bit about hypertensive crisis? We deal with hypertensive emergency a lot in the emergency room. Okay. Hypertensive emergency is when you have a BP greater than 180, 110 to 120 millimeters of mercury, right? With signs of end organ damage. Okay, that means that you visibly get symptoms or signs that show that there is an end organ damage. So the way to go about it systematically is to start from head to toe. So from the head, you have CNS, right? So strokes, the patient may be having signs and symptoms of stroke, maybe facial deviation, lower limb weakness, etc. Okay, there may be retinopathy, so from head down. Then go to the heart, they may have MIs, aortic dissection, so they'll come with chest pain. Okay, renal Then you go down again, kidney. Okay, so they may be having AKI. Maybe they'll have, signs and symptoms of all of these. Okay, from top to bottom. So that's how you approach it. Okay, you look at the organs from head to toe. Then you'll be able to pick up the signs of end organ damage. So that's hypertensive emergency, where the BP is this. Okay, but we have signs of end organ damage. However, for urgency, there are no signs of end organ damage. Okay, the person is a ticking time bomb waiting to get into you know, this situation. All right, we don't want the person to get here. Okay, so in both cases they are hypertensive crisis. All right, but this is a much lower grade as compared to this one, because here we do not have no signs of end organ damage. All right, while in hypertensive emergency there is end organ damage. You see, it's very simple, so don't let it confuse you again. Okay, now, even with hypertensive emergency, all right, I'm sure you've heard of the term malignant hypertension. You are not really sure what it is. So, malignant hypertension falls under hypertensive emergency. What is malignant hypertension? Malignant hypertension is when the person is in hypertensive crisis, okay, specifically hypertensive emergency, all right, where there is end organ damage. But you will say that a patient has malignant hypertension if there is retinopathy. Okay, so maybe on fundoscopy, you'll pick up um, papilledema, flame-shaped hemorrhages, exudates, you know. So that is when you say that the patient has malignant hypertension. When the patient has a BP of greater than 180, 110 to 120 millimeters of mercury plus retinopathy, all right? Or in the absence of retinopathy, when there is no retinopathy, there is damage to a minimum of three different target organs. So maybe CNS, heart, and then maybe kidney. Okay. So a damage to a minimum of three different target organs when there is no retinopathy picked up. Okay, so that's when you say a patient has malignant hypertension. So remember, malignant hypertension is a subset of hypertensive emergency. It just means that the patient has this BP or higher plus retinopathy. Okay, if there is no retinopathy, but you are able to pick up a minimum of three different target organ damages, then you have malignant hypertension. So that's where malignant hypertension comes in. Okay, so that's very simple. Now let's look at the clinical features, okay, of hypertension. Remember that for the classification, we have primary hypertension and secondary hypertension. Primary hypertension being that there is no underlying cause and it makes up majority of the cases. While secondary hypertension is about 5% and there is an underlying cause. Okay, so what are the clinical features of essential or primary hypertension? None. None at all. That's why it's called a silent killer, because it is asymptomatic. Okay, it can be so asymptomatic to the point of having hypertensive urgency where you still don't have symptoms, but the BPs are shooting to the skies. Okay, so remember, there are no symptoms of essential hypertension. None. Zero zero. Okay. Somebody may argue. Sometimes the patient has a high BP and the person is having headaches, dizziness, palpitations. These symptoms are non-specific. All right. They are very non-specific and are not necessarily symptoms of hypertension. Remember, it is a silent killer and it is asymptomatic. When the person starts having headache, dizziness, blood fishing, then we are going towards the complications of hypertension. Okay, but the patient can be walking around with very high BPs and then there are no signs and symptoms. Okay. Then you would ask yourself, okay, so if there are no signs and symptoms, if the patient comes to me, what am I going to write in my history? You need to write a good history about the person's risk factors. Remember, essential hypertension, you can't find the underlying cause, but you can find risk factors. Okay, so you write down all the risk factors. We've seen the risk factors in the previous video. Okay, I gave you a simple way to remember the risk factors for hypertension. Remember, they are non-modifiable and modifiable. So remember them, you can tell a story. How do you remember them? For the non-modifiable, everybody is born into a particular continent, into a particular race. You come from a family. In your family, when you are born, you have a particular sex. It could be male or female, and you eventually grow old. So that's a story to help you to remember. So African race, positive family history, male sex, being elderly, these are the non-modifiable risk factors. But the modifiable risk factors are the following. Of course, you can also tell a story. Remember, I said that when you are so stressed, you don't want to do anything, you prefer to lie down, you stay sedentary, and once you're sedentary, you begin to put on weight, you become obese. All right. And usually, once you are stressed, you rather not take fruits and vegetables, you rather take a lot of junk foods. Okay. A lot of junk foods contain excessive salt, and people too, when they are stressed, they prefer to take alcohol and smoke to cope with the stress. All right, so this is the story that helps you remember all the modifiable risk factors of essential hypertension. Okay, so this can make your history very rich. All right, then you would ask yourself, okay, but if all of these are present, doesn't it mean that the essential hypertension has an underlying cause? Isn't stress the underlying cause? Isn't low fruit and vegetable intake the underlying cause? No, it's just risk factors. Okay, risk factors are not the same as causes because not everybody with a family history of hypertension develops hypertension. Not every elderly person has hypertension. Not all Africans have hypertension. And for stress, you know that health workers are very, very stressed. And not all health workers develop hypertension. So these are just factors that increase your risk. The fact that that risk factor is present may not necessarily mean that you develop hypertension. That is why you can't say that these are the underlying causes. They are just risk factors. Okay. What else can you add to your history to make it very rich, even though the person may not have presented with initial signs and symptoms? You can ask for signs and symptoms of complications. You want to rule out end organ damage. Okay, so you start from head to toe. So from the head, you find out symptoms of stroke. Has there been any loss of consciousness? Sorry. Has there been loss of consciousness? Has there been weakness, limb weakness, aphasia, facial deviation? Okay, you come to vascular dementia, vision loss for retinopathy. Then you come to the heart, coronary artery disease. That the person had chest pain before, shortness of breath, bilateral lower limb swelling, heart failure, bilateral lower limb swelling also for renal failure. Okay, peripheral artery disease where you can have things like intermittent claudication, rest pain, etc. Okay, so these are the complications that you can find out. You want to rule them out. Okay, so this can also make your history rich for hypertension. Okay, and remember that when you write your diagnosis for hypertension, don't just write hypertension. Write primary or essential hypertension because we didn't find an underlying cause. We just know that there were risk factors. Okay. So always in your history, after you are done clerking your patients, write primary or essential hypertension. Don't just write hypertension. Are you dealing with secondary or primary? Okay. Now let's talk about secondary hypertension. Remember that secondary hypertension, there are underlying causes, and we saw the mnemonic O vera. Okay, so if you have not seen this mnemonic, please go to the shorts playlist. There is a very nice music you can groove to that will help you to remember the O Vera mnemonic. Okay, V for vascular, E for endocrine, R for renal, A for medications that starts with the letter A, and O for others. So that's how you remember it easily. Now, for the clinical features, you also go using this mnemonic, and then you'll be able to remember what you are supposed to look out for. Okay, but generally, we need to have some general clues that will help you, that will point you to the fact that we may be dealing with secondary hypertension instead of an essential hypertension. If the person is of a young age, has a very young age, with no family history, no risk factors, you should be thinking about secondary hypertension. If it's a sudden onset in a previously normotensive person, if the person has been on medications but it's not going down, the BPs are still not going down, okay, about a minimum of 3, and the patient's BPs are still not going down, you should be thinking that maybe we are dealing with secondary hypertension, so we need to probe further. Okay, and using the Vera mnemonic, starting for the vascular, we saw that we had coarctation of the aorta and renal artery stenosis as one of the causes. So you'll see things like radiofemoral delay, high BP in the upper limbs, and low BP in the lower limbs for coarctation of the aorta, then renal brewing, all right, for renal artery stenosis. Then also we come to endocrine. In things like Cushing's syndrome, the person will be having a moon phase, there'll be central obesity. All right. You can have palpitations, tremors, and then anxiety when it comes to pheochromocytoma and then hyperthyroidism. Okay, then cold intolerance, weight gain in hypothyroidism. If you are at this point confused as to why hypothyroidism can cause secondary hypertension, please remember that hypothyroidism puts you at risk of an increase in systemic vascular resistance. Okay, if you want more details, please check out the pathophysiology video. That's where I go into the details of how hypothyroidism can cause secondary hypertension. All right. Then for renal, you may have chronic kidney disease, you have bilateral pitting edema, you can even have anasaka. Okay. Then for medications that starts with the letter A, so in your history, you want to find out is a patient on antipsychotics, is a patient on antidepressant, because some antipsychotics and some antidepressants can actually give patients a high BP. All right. So analgesia is the person taking NSAIDs, specifically NSAIDs, right? The person on NSAIDs, that's the person use anabolic steroids, is the person on amphetamines, all right? You need to find these out in your history. Let your drug history be very rich, okay, to rule out the causes of secondary hypertension. We tend to ask all these other questions, but we forget to focus on the drugs, right? So let's take note of it. Anytime somebody comes with hypertension, make sure that your drug history is very rich. They may be taking these medications, but if you do not ask them specifically, are you on any antipsychotics? Are you on any antidepressants? Especially with the stigma surrounding mental health, people don't like to disclose. Okay, so you need to find out. All right. Then there are others. So things like obstructive sleep apnea. All right, they'll come with symptoms like daytime sleepiness, loud snoring. All right, then illicit drug use. So you ask about use of cocaine, and then also some oral contraceptives are also known to cause hypertension. So you need to ask all of these questions, okay, to rule out secondary hypertension. So you see that your history will be very, very rich when you are taking it from a patient who has hypertension. You need to ask all these questions to rule out secondary hypertension. Okay. So how do we investigate? Now, for investigations, we will do blood workup and then we'll do other things. All right. So for blood workup, this list isn't exhaustive. Okay. You need to do your baseline, full blood counts, BUE and creatinine. Remember, the kidneys could be involved, lipid profile, there could be atherosclerosis, okay, high lipid levels for people who are obese. Even if you are not obese, you need to check, all right, thyroid function test, serum cortisol to find out all the underlying causes if it's secondary hypertension. Okay. Then for others, you start from head to toe. Remember, when you are looking at the complications, you start from head to toe. Okay. When you're investigating, you also start from head to toe. So from the head, what can you do? Things like stroke, you can do a head CT scan. You come to the eyes, you can do fundoscopy. Do you get it? You can do a head CT scan or MRI, okay. Then fundoscopy. Then you come to the heart. You can do an ECG, you can do a chest X-ray, you can look out for cardiomegaly and arrhythmias, etc. Okay, as complications of hypertension. All right. You can also do an echo, okay, to look at what's happening with the valves, whether those are contributing to heart failure, which is also a complication of hypertension. All right. You can also do abdominal ultrasound to look at the kidneys, okay, and then the liver as well, okay, because in right heart failure, you can have them hepatomegaly as well. Okay, then you go down to the legs, Doppler ultrasound. Complication can be peripheral artery disease. So you want to look at all of that. So you see that we started from head to toe. Once you look at the patient from head to toe, you can remember all the investigations that you are going to do. You can remember all the complications, at least most of the complications that you'll be dealing with when it comes to hypertension. All right. So that is it for this video. I hope it was very helpful. I hope that it made so much sense. If you have any questions, comments, please leave them in the comment section. Okay, and I'll answer them. Right. You can also reach out to me on Dr.MiraTeaches at gmail.com and I will reply. Okay. So thank you so much for watching. Remember, keep studying, keep shining, keep learning, and glow like the African sun. All right. Bye.